Hello, student. Today's lecture is going to be about cardiovascular disorders. Next slide. The cardiovascular system, very important system. It's about the size of a fist. It involves, the heart and the circulatory system. Again, it's essential for the body part. If it failed to function, there is less output, and that is significant. Next slide. The growth structure of the heart is pretty simple. The heart is composed of layers. The fibrous outer layer, we call that pericardium. Myocardium is the middle layer, and the endocardium, which lines the inside of the heart. Next slide. And then you have chambers. The heart has 4 chambers, right? 2 of those chambers are called the same, and the other 2 are the same. So it's either they are ventricle or they are called atrium. The ventricle are, they serve a bigger deal because they actually pump, right? Versus the atrium, which receive blood. So you have the right atrium, the left atrium, and the right ventricle and the left ventricle. The left ventricle looks bigger than the right ventricle because from the left ventricle, the blood supply goes out into the systemic location. All right, and within the heart you have valves, right? Inside of the heart, there are valves that separate the chambers, and it prevents backflowing of blood. So when the blood leaves the right atrium, it goes into the left atrium. Into the left, from the left atrium to the left ventricle, and so the valve that is between the atria and the ventricle, we call those atrioventricular valves, and those are bicuspid and tricuspid. The valves between your aorta and your pulmonary to the lung, we call those semilunar valves. So that is the aortic valve and the pulmonic valve. Important roles because, again, it's supposed to be like a one flow way of blood, right? So when problems start occurring with these valves, either they get hard, stenosis, or they become flappy, regurgitation, it creates a problem. All right, and so we'll talk about those later. Next slide. Yes, so again, the blood supply, there is the left side, the left coronary artery and the right coronary artery. These are the supply to the heart itself. The heart itself needs, blood supply. The left coronary divides into 2 major ones. So you have the left anterior descending and circumflex. Most of the left ventricle and this, this LAD provides the supply of blood. And circumflex, you get supplies the left atrium, the lateral and posterior left ventricle, and the SA node in 39% of the population. The right coronary artery, you have the right atrium, supplies the right atrium, the right ventricle, the inferior part of the heart, the SA node 59 and AV node 88. And this is really important because if there's a decrease in blood flow, these are the areas that are affected. Next slide. All right, so this is what I just regurgitated for you so you could understand fully. So the heart itself needs its own blood supply. You have the left and right coronary arteries. You see those arteries in your neck, and it's important as a nurse to assess them. And when you're assessing these arteries, the pulse, you are palpating one at a time, not both, because you're going to stop the blood flow to the heart. You're also going to listen to this artery to make sure that there's no bruit, so that if it's not obstructed, all right, so you can auscultate those arteries as well. Next slide. We talked about the valves already. So there are the valves between the atrium and the ventricle. So that those are called atrioventricular valve. Those are the tricuspid and the bicuspid valve or mitral valve. And then you have the valves between the pulmonary, from the pulmonary to the pulmonary vein, right there, the pulmonary valve. So from the right before the pulmonary circulation, that's where the valves are. And then you have the aortic valve, which is right before the blood is ejected out into the systemic circulation. Next slide. And then you have the conduction system of the heart. The heart has its own specialized tissue that allows rapid transmission of electrical impulse through the myocardium. So the SA node is the pacemaker. It's the main pacemaker of the heart, right? So it has normal rhythm, it can excite itself. Usually have an inferent firing rate of 60 to 100 per minute. But changes are based on the body's need. Next slide. So this is what we just repeated. Next slide. And then you have the atrioventricular node, which is the impulses are conducted from the SA node, and then it goes to the AV node. After a slight delay, it allows the atrium to contract and then fill the ventricles with blood. The AV node sends the electrical impulse to the ventricles through the bundle of hairs, right, which is also located in the septum. The SA node does not, the rate is a lot higher than the AV node, so the AV node takes over the fire rate of about 40 to 60. Next slide. And then cardiac cycle, there is, it's part of the autonomic nervous system. There is systolic and diastolic, and with systole, what you're seeing is that the ventricle rise causing the atrioventricular valves to close, right? And then, which, like I said earlier, it's going to prevent the backflow of blood into the atrium, and the pressure rise inside both of the ventricle, which forces the pulmonic and the aortic valve to open, and then blood is injected into the lungs and the aorta. These closing of valves, when you're listening to the heart sound, that's what you're listening to, S1 and S2. When those valves are closing, the ones that close first are the atrioventricular, so that's S1, and the ones that close second, that's semilunar valves, that's S2. When the blood from each of the beats has been ejected, and decreases to the pulmonary, the aortic valves then close, and then this process begins all over again. Next slide. So diastole, systole and diastole. So contraction is systole, diastole is relaxation. It's important for these two processes to take place. So the ventricles are relaxed and the AV valves are open. Blood returns from the body, flows into the right atrium, and then towards the end of the diastole, the atria contracts when it receives the impulse from the SA node, and then the blood is pushed into the ventricle. The systemic blood vessels are the sympathetic responses, which causes vasoconstriction, and parasympathetic, which is dilation. So these two are also important. And then you have, next slide, the baroreceptors. These are mechanism to help, and they are to cope with the changes that are taking place. They are located in the walls of the large systemic arteries, and it rises in pressure, results when the baroreceptors transmit a signal to the nervous system to inhibit the sympathetic nervous system. Other signals in turn send to the circulatory system to reduce the pressure back into the flow. So pretty much the result is helping with decrease in the heart rate, vasodilation, and decrease the blood pressure. Next slide. So in terms of the system assessment of the cardiovascular system, it's really important in us to assess. So pain is a vital sign, so it's part of the nurse's role to evaluate the patient's history, assessment of chest pain. When it occurs, so when you're asking about history of present illness, and in this case chest pain, you want to ask about the onset, when it occurs, any precipitating factors that are accompany any radiation of the pain, any other associated symptoms with it, so nausea, dyspnea, sweating, fatigue, palpitation, etc. And you can rate the pain between 0 to 10, using a numeric scale. You can use the face scale, and so forth. Other assessment information that the nurse may want to gather is, just the basic, signs that tells you something is wrong with the cardiovascular system. There's dyspnea, there's cyanosis. In cyanosis, you should pay attention to the color of the patient's skin, because on a darker person, you will not be able to see cyanosis other than looking in areas that can give you a better analogy. So the nail beds, the mucous membrane. You want to find out if you're fatigue, any palpation, any syncope, hemoptysis, edema, any condition of the extremities like their pedal edema, that kind of things. Next slide. And then evaluate the veins and the arterial pulses, so you're going to, inspect. Inspection is the first sign of the physical assessment. So remember, physical assessment, you inspect, you auscultate, you palpate, you percuss. So definitely for the cardiovascular system, there's inspection. You're going to look at the veins, so the neck veins, so the jugular vein, are they distended after the head of the bed is raised? They should be, when they're at the flat position, the JVD should be distended. If it's not, then let me tell you that they may have fluid volume deficit. So it should be elevated. It should be distended at a lower level. Arm and arm veins, you can also assess that in leg and foot veins. Somebody may have other venous problems that you will see. And then of course with the arterial, central, and peripheral pulses, you got to palpate all the pulses that are there. Next slide. So the pulses site are, pretty much everywhere. So you have the temporal artery, the femoral artery, the facial artery, the carotid artery. So this diagram is showing you all of this. The radial artery, the femoral artery in the groin area, popliteal, posterior tibia, dorsalis pedis. So it's important for you to be able to assess this and actually point it out on an exam, on a paper, because you may be given a hot spot. They may show your body and then put a line saying what side is that, what pulse side is that. You should be able to identify them. Next slide. Auscultating the long sound is the next step. So it's really important when you're listening for the lungs. You're going to listen for, is there any crackles? If it is, then it may tell you that there's fluid buildup, and this is suggestive of probably congestive heart failure. Next slide. And you're auscultating for the heart. So you're going to listen and you're going to hear S1, S2. So when you're listening, you got to assess for the frequency, the pitch of it, the intensity, the duration, and also if the murmurs are there. And gallops, these are extra heart sound, S3, S4. So usually diastolic filling sounds when the blood enters the chamber that are stretched. And then S3 is early sign of heart failure. S4, this left ventricle may have some decreased compliance. So it's important, as a practical nurse, when you're listening to the heart, know your normal. So if you know what S1, S2 sounds like, and if you hear anything extra, then you can definitely call your supervisor, in this case your RN or your physician that you're taking care of. Next slide. Murmur, turbulent blood flow that causes murmur. Here, what you have is the blood is heard when the blood flow through a malfunction valve. Maybe is it stenotic, or is it a valve that's incompetent? Then you hear this murmur. Systolic murmur is heard during the first heart sound, S1. Next slide. Diastolic murmur is heard during the second heart sound. And then you have hollow systolic murmurs, which is heard throughout systole and sometimes heard like a sound, whoosh, instead of an S1, right? And then you have pericardial friction rubs. These are seen in people that have pericarditis. So you hear this harsh grinding sound throughout systole and diastole. So again, for your level, what you want to do is just know the normal and call for help when you hear something that is not normal. Next slide. So the next thing is carotid blood vessels of Brury. So when you're listening, you can auscultate, the carotid, and usually if there's an obstruction, partial obstruction, you can hear a bruit. All right, and then palpate and percuss the thorax, and when you're palpating, you're palpating for thrill. And then evaluating chest x-ray, the x-ray will show us an enlargement of the heart and if there's fluid in the lung. Next slide. All right, assess the lung sounds again. In heart failure, you will hear like basal or crackles most frequently because of extra fluid that goes into the lung, right? And then we're going to assess for any factors for cardiac disease or risk factors. So what are this patient? Are they smoking? Do they take high fat diet? Do they lack exercise? Are they exercising? Are there any current medical diagnosis with hypertension? What about their stress level? What about diabetes, obesity, family history, genetics? So it's important to collect all of this data. So you have your subjective data and then you have your objective data. So you've done the assessment yourself, but it's important to have collected certain information about your client's lifestyle. Next slide. Diagnostic tests and procedures are also very important when it comes to knowing what's wrong with the heart. So you have CKMB. CK is a plain CK. It is not as specific because it tells you that muscle from anywhere else, like from rhabdomyolysis, but MB is more specific, so specific cardiac enzymes, and usually that peaks 24 hours after a myocardial infarction. So 24 hours after an MI, this level will be high. Troponin is any elevation because it's more specific, tells you myocardial injury or infarction. And then you have myoglobin, which is used to rule out MI, usually within 2 to 7 hours after the onset. Next slide. BNP, right? Brain natriuretic peptide, so which helps to diagnose heart failure. It tells us the severity of it. All right. It may be used to help evaluate the patient who have risk for chest pain and so forth. So a high level can tell us that the patient has an increased risk, and definitely a higher level can tell us a diagnosis of heart failure. And the severity of it, it definitely will be able to help us with treatment protocol. Homocysteine is a strong indicator for cardiovascular disease. So elevated level tells us that the patient has risk for cardiovascular disease. Next slide. And then platelet elevation puts the patient at risk for thrombosis. So it's important to look at that to help us assess what's going on with the client. Hemoglobin level, what hemoglobin does by carrying oxygen to the cell. If moderately or lower, if the patient is anemic, that may precipitate a cardiac infarction because the patient is not getting adequate blood oxygen flow to the cells. Coagulation factors are also really important. So like patients that are on heparin, TPA may be needed. So heparin, aspirin, TPA are thrombolytics, so they dissolve existing blood clots, may be used. Next slide. Lipid assessment. So remember, we said that one of the risk factors for cardiac problems is diet. So the lipid assessment, it's really important. So you're looking at your total cholesterol, LDL, HDL, and triglycerides. So that total cholesterol should be less than 200. The higher the HDL is good because HDL is good cholesterol versus LDL. Potassium and magnesium are also very important because we need to evaluate for potential dysrhythmia. If the levels are low or the levels are high, they can lead into problems. So it tells us, making sure that we monitor this level. Calcium is needed for cellular depolarization and repolarization. It also plays a role in, blood clot. Blood glucose, individuals that have high level of glucose and they have a risk for cardiac disease. So we want to always rule out cardiac diabetes. All right, next slide. Other diagnostic tests are EKG. EKG is really, really one of the most, inexpensive, non-invasive tests that is done. Evaluate the left ventricular. It would evaluate left ventricular hypertrophy. It also which would give us an indication of any risk factors for other heart problems. There are leads that are put on the patient's chest. The 12-lead EKG looks at a broader range of the heart, and definitely it can help us evaluate or diagnose myocardial infarction and its location because each of the lead tells you where it's looking at. So it would help us in assessing, the patient's MI, right? Like ST segment elevation would give us an indication of an MI. Next slide. Other diagnostic tests are cardiac cath. These The cath would help us observe coronary vessels for blockage or any strictures. It can also evaluate the ejection fraction of the heart and valvular function. Echocardiogram, ultrasound of the heart. Again, it's usually non-invasive. There's different types of it. The TEE, transesophageal echocardiogram, or transthoracic echocardiogram. Thoracic, it's on the outside of the body, and trying to assess. It would tell you the structural activity of the heart. So it can tell you EF, the valve, if there's problems, is it stenosis, is it regurgitation, other structural defect. Whereas the EKG or ECG would tell you the electrical activity of the heart. Next slide. So this is what I was talking about, the transesophageal echocardiogram. A little different because you are putting something down to get closer to the heart. So it looks, at the back of the heart. And then, of course, you have angiography, which uses a contrast. So part of your job is to make sure that the patient is not allergic to any contrast dye, and to flush the kidneys afterwards by drinking plenty of fluid. Next slide. Coronary artery disease, here what we're talking about is narrowing or obstruction of one or more of the coronary arteries as a result of atherosclerosis or accumulation of lipid-containing plaque in the artery. See the picture, diagram B is clearly showing you, A is showing you normal versus B, which shows you some plaque accumulation. And usually you do not see symptoms until after over 40% of the artery is obstructed. Next pane. Next slide. All right, and so chest pain, angina pectoris is the episodes of chest pain or pressure from the coronary artery blow that is not adequate. So remember that plaque that I was telling you. So when you have about 40%, that's when you will realize the patient will have chest pain. So other than that, they're asymptomatic. So when there's an obstruction, what happens is there's decreased oxygen supply to the heart, right? And so the pain tells you that. The physical exertion can cause the angina because of the increased need for oxygen to the heart. And when that happens, so the patient is getting up, the patient is doing some yard work, and she started having pain, so because there's a exertion, increased amount of oxygen, so the patient's going to have that pain. So what you expect in something that is stable is once the patient stops doing the activity that is causing the chest pain, the pain goes away. So that's called stable angina, right? Because the pain is relieved by rest, all right? Or the pain is relieved by the nitroglycerin, that the patient may take, right? Next slide. So unstable angina is chest pain that occurs without a certain pattern or without any exertion, right? Other risk factors of this include exposure to cold, eating a heavy meal, stress, and so forth, right? And it's usually unstable because even if the patient sits down, it doesn't go away. All right, next slide. So what are the clinical manifestations of coronary artery disease? Like I said, many of them are asymptomatic because, the plaque continues to build unless ischemia is involved. So chest pain or pressure, and usually they describe it as radiating to the jaw, back, or shoulder. There's other symptoms, palpitations, weaknesses, dyspnea, syncope, nausea, vomiting, excessive fatigue. And of course, if you look at the EKG, that electrical activity of the heart, you will see some changes, and the changes are usually the T wave or ST segment. Next slide. So coronary ischemia or angina, again, it's a silent angina. There's no symptoms. Silent angina means no symptoms, but EKG changes. Often seen in diabetic clients, because remember, the nerves in diabetes are destroyed. So a non-compliant diabetic client, so even if, since the nerves are destroyed, they would have pain, and they won't even feel that they have pain, right? So it's called silent angina. But if you look at the EKG, you'll see the changes. Diabetics can have, like I said, a myocardial infarction and not know that they've had it because of this. So again, the EKG will usually show us that. Next slide. So what are the teachings for angina? Well, if they are engaged in activities when that happens, definitely stop, right, and rest, right? And if the patient knows the specific activity that takes on that problem, so make sure that they probably treat prior to doing the activity. For example, you want to do some yard work and you know that you're going to have chest pain and you know that you have angina, and so you can take some nitroglycerin prior to prevent the pain from occurring. If the angina occurs, stop, rest, and take the nitroglycerin. And so what we tell the patient to do is to take the nitroglycerin, one every 5 minutes, and times 3. And if it doesn't work, then you need to call 911, right? Call 911. Next slide. So again, nitroglycerin is a drug, really good. It's vasodilate. In 30 minutes of onset, it peaks in about 2 to 5 minutes. So the effect when they take it lasts for like 30 minutes. If the chest pain is not relieved by the first, then again repeated by the second and then the third, right? The second increases what the first did by vasodilating even further, right? So it's very important for us to make sure that the patient understands to sit down, because they can get dizzy, they can faint, which creates another problem, safety issues. Because nitroglycerin, what it does is vasodilate, and when it dilates all the vessels in the body, not just the coronary artery disease. Very potent drug, but it does what it needs to do to relieve the current situation that the patient is having. Next slide. And unstable angina, again here, the goal is to eliminate, right? To eliminate the chest pain that the patient is having, right? To decrease the myocardial oxygen demand and increase the oxygen supply to the myocardium. That's what we want to do, goal number 1. Goal number 2 is to reduce the cardiac workload, and goal number 3 is to stabilize the rhythm, right? Next slide. So how do we do that? There's an acronym that is given in advanced cardiac life support, ACLS, right? It's called MONA, but the order is really ONA, right? So O is oxygen. So we want to give oxygen 2 to 4 liters per nasal cannula, right? Unless there's other issues. And then N is nitroglycerin, right? If they're not already tried, try it out into the hospital. Usually, like I said, 3 of them that you can do. And then you have M is morphine. Morphine is going to help with the pain, but also going to decrease anxiety, and also is going to increase the venous pooling. And then you have A, which is aspirin, which prevents the platelet aggregation at the site of obstruction, which can cause more obstruction. You don't want that. Next slide. All right, so making sure that we do the baseline vital signs and 12-lead EKG, and monitoring for any dysrhythmia that may happen, which can occur at any time, but the risk is greatest between the first 1 to 2 hours of the unrelieved angina. And then monitor the respiratory for respiratory distress, because of making sure that they don't go into heart failure. Next slide. Now we're about to start talking about myocardial infarction, different from an angina, because one is pain, one is actually a problem, right? Because there's ischemia, right? Acute ischemia. Next slide. So MI, so there are some signs. So what you have is the patient has an ischemia of one or more of the coronary arteries. It depends on where the problem is. So, but there's usually a clot or a vasospasm. If the major or the left main artery is blocked, then you have a massive MI usually. So unless their circulation is restored within 6 hours. So when it comes to MI, time is muscle, right? So it will lead to infarction, which means necrosis of the heart muscle beyond the blockage, which is not good. So how do we diagnose it? Again, we can do a 12-lead EKG and other diagnostic tests. Remember, I talked about the troponin level, the CKMB, and other tests. Next slide. So signs and symptoms, again, very typical. A typical presentation would, include severe pain, usually 10 out of 10. They say that it radiates down the arm and up the jaw. It's like an elephant sitting on my chest. They may be nauseous. They feel like a sense of impending doom. This will usually last for 30 minutes or more and respond only to, not nitroglycerin, to morphine, right? Also may have diaphoresis, dyspnea, and dysrhythmia. Next slide. Female may not present typically, so the symptoms, they may, describe it very differently from that of a man. So they may feel like a burning sensation in the upper abdomen, lightheadedness, and upset stomach, and sudden weakness or unexplained tiredness. Next slide. The elderly also may not present typically, so they may not notice the severe pain, but will complain of other symptoms, especially any type of gastrointestinal discomfort. Next slide. So this is a 12-lead EKG. So what you see with a normal EKG, see how all the waves, the P wave, QRS, and T wave. These waves are normal, and the spaces, the distance between each one is normal. So you see P wave, QRS, and then T wave. And in ischemia, see how the P wave, the T wave is peaked. Injury, see how the ST segment is elevated. In acute MI, you see that T wave inversion, and all MI, you see that U wave. So these are, the cardiac nurse has to learn this and understand and appreciate it, but it's more important for all nurses to just understand what the normal looks like, because if you know what normal, you can always question what is not normal. Next slide. So in general, ST depression, T wave inversion, strongly suspect ischemia. The ST segment elevation is suspicious of myocardial infarction. And in ischemia, usually you will see tall inverted T wave, which shows the impact. ST segments may be depressed in angina. Next slide. So injury, again, you will see the elevation of the ST segment and the T wave inverted. Maybe ST segment may be elevated and T wave may be reverted, right? Next slide. Specific areas of injury, the LAD, is called the sudden death coronary artery because it supplies majority of the heart from what we talked about in the beginning. So obstruction leads to anterior and septal MI, which is 25% of all MIs, most likely to have a heart failure and ventricular dysrhythmia. So they go into VFib, which creates even more problem. So the V2 to 4 in the leads will look at the anterior area of the heart, and then the circumflex looks at the posterior and lateral wall MI with sinus dysrhythmia. And you can look at the leads. There's AVL and V5, V6, and so forth. So it's important to look at the leads to know where the injury is. Next slide. And as we talked about before, you can do some other tests, the laboratory test, myoglobin, troponin, CK, and BNP to make sure that there's no the risk factor, but definitely to see if it's heart failure, the severity of it. Next slide. There are some collaborated management. You have independent nursing action, where the nurse do not need a doctor's order, but you need some collaborated stuff. So immediate assessment is usually needed to assess the vital signs, to assess the O2 saturation, to make sure there's an EKG is obtained and the physician reviews it, to perform a brief targeted history and a physical exam, focusing on the eligibility for fibrolytic therapy, because we may want to give them some, thinners and so forth. Next slide. Immediate general treatment, again, we talked about MONA, so you have to make sure that there's an established patent, access. So IV access is important. Oxygen at 4 liters, nasal cannula, aspirin, making sure they have that to thin the blood, nitroglycerin, sublingual spray, morphine IV needs to be given, and the PN student the PN nurse do not push any IV. Next slide. And you have beta blockers can be used, a possible medication to use if the heart rate or blood pressure may elevate with continuous chest pain. Beta blockers, they depress the pumping action, and so you want to see if the patient has a high heart rate and high BP. Next slide. Okay, so use of beta blockers, so these are the different things that you can use beta blocker for, which I thought is really, really cool. So glaucoma, there's beta blocker for the eyes, there's migraine, there's thyroid storm, there's hypertension, angina, cardiac arrhythmia there. So it's a really, really important drug that you need to know, the beta blockers and an LOL. And there are some contraindications for people that may not take this, so you need to figure out what those are. Next slide. And then reperfusion strategies are important because, most of these conditions happen because of obstruction, right? So we want to reperfuse the area, and you can make sure that we are giving the patient thrombolytics, which will break down the fibrin and that binds the clot together. So usually the time of symptom must be less than 12 hours. Hemorrhaging is a problem here to reperfuse, so you have to assess for bleeding tendency. Next slide. So these are some of the agents that are used as thrombolytics, TPA, streptokinase, followed by some prevention, a drug that prevents blood clots, such as heparin. Next slide. So the mechanism is for thrombolytics is they break it down. They break it. They don't prevent it. They break what has already existed. Next slide. There's another slide. This is pretty nice, and I think credit is Judy Miller's. And so she's telling you the thrombolytics, so they work. What they do is they are considered clot busters. They go in and just break things down. Next slide. You have the percutaneous transluminal coronary angioplasty. So here what you have is the balloon is inserted in the area for blockage and is held open for approximately 15 minutes and pushes the plaque to the side so that the coronary artery can become more open. It actually 20% reocclude in 6 months, so it's not something that you just need to do it immediately, but it's not a permanent fix. Next slide. And this is a picture showing you how this process works. Next slide. And then you have stent procedure, which is similar to the PTCA or cardiac cath. So here you have a stylus that is inserted in the right groin and wire. So it's advanced up into the blockage. So the stent is placed inside the blockage and open up, and then it forces the vessels to open and stay open. It takes about 3 weeks for the epithelial tissue to lay down and the stent and becomes permanent part of the vessel. Because this is a foreign substance, it requires aspirin and sometimes antiplatelet therapy to prevent clots from forming over the stent. Next slide. This is a picture showing that. Next slide. So this slide is talking about the care after that. So we're monitoring the vital signs. We're assessing the distal pulse, the groin site for bleeding, for swelling, for hematoma. Usually the patient is in bed rest with the limbs straight for about 6 to 8 hours, and sometimes we may want to put a sandbag which gives pressure over the groin so that FEM stop. We want to stop any bleeding from occurring. Antiplatelet agents to prevent the thrombosis from forming are, Agostat, for example. Next slide. Well, this is just a slide that shows you, those antiplatelets. Aspirin is right on top there, and the indication for it, the different things that they use for, and the side effect of the drug. Yeah, so Ticklid is also another one, and again, thrombocytopenia, neutropenia. So it's important when you are treating your client to know the drugs that they use and why they're using it, and definitely some of the adverse effect that you should be monitoring for. Next slide. Post-procedure care, again, so we're going to monitor the IV nitroglycerin, and usually that is done by a registered nurse given IV nitroglycerin, because we want to prevent any coronary artery spasm. And then aspirin once a day, that's permanent thing. And then assist planning lifestyle modification, because modification, you have modifiable and non-modifiable risk factors, the diet and exercise and keeping the blood pressure stable, keeping your cholesterol level normal. Those are lifestyle, those are things you can modify. You can't modify your gender, your age, your race, your genes. You can't modify those things. So a lot of teaching after a patient has some coronary artery problems to make sure that they remain well. Next slide. Rehabilitation, cardiac rehab. Again, we're teaching them about diet, progressive exercise, encourage changes of modifiable risk factors like we talked about. And again, the modifiable risk factors are weight loss, stress reduction, lipid lowering drugs, antihypertensive drugs, aspirin, and which starts 2 to 3 days post-op and will remain on the aspirin indefinitely. Next slide. And for cardiac surgery, bypass is usually sewn from the aorta to between the blocked area, the side of donor, usually is the graft, usually the saphenous vein, in the left or in the leg or left internal mammary artery. So pretty much the collaborated management, you're looking at making sure that patient doesn't have fluid overload. So you need to assess for that. So how do you know that they have overload? The weight can usually tell you that. So there's a gain in weight, 5 to 10 pounds on fluid. And diuretics is usually given post-op so that the potassium is monitored, to pull the fluid, and potassium is monitored because, since, furosemide or Lasix is usually used, and Lasix wastes the potassium. So you're going to monitor for hypokalemia. Also monitor the magnesium level, as low level can cause cardiac dysrhythmias. All right, next slide. Temporary pacemaker wires often are placed after surgery to use PRN. We have to assess for bleeding. More than 100 mLs an hour from chest tube is too much loss. Approximately 15 to 20% will experience AFib post-op. So atrial fibrillation, we want to monitor that with CardioSam, and making sure that we're monitoring to ensure that there's no blood clot. So these guys are usually on anticoagulants, like Coumadin, right? Next slide. So pain management, try to control the pain, encourage early ambulation, because immobility can cause a lot of problems, such as constipation, such as impaired skin integrity, such as pneumonia, impaired skin. So it's DVT. So it's important to get them up and moving as early as possible. Intensive spirometer is used and encouraged so that it can help expand the lung. We're going to change dressing on chest and the leg graft site. We're going to monitor the vital signs, the lung sounds, the heart sounds, to make sure that there's no new cardiac changes that are occurring. Next slide. We're going to monitor the weight. It's important to know the before and after weight. So pre-op weight is important. Monitor the eyes and nose intake should be equals to output. The labs, the potassium, the electrolytes, the EKG changes assessed for stroke, cardiac tympany bleeding, cardiac dysrhythmias, and post-carotid syndrome. These are all complications that you may see. Next slide. So these are the complications: stroke, cardiac tympany bleeding, cardiac arrhythmias, and post-carotid syndrome. So let's talk about the next slide. Cardiac tympany. Here what you have is the fluid between the heart and the pericardial layer starts to compress on the heart and prevent the heart from filling normally. So less room to fill because it is compressed, right? So therefore reducing the venous return to the heart, and then causes decreased cardiac output. Next slide. So what are the signs and symptoms? Well, narrow pulse, pressure, shortness of breath, fatigue, distant heart sound because of the fluid, chest pain, fullness, decrease in systolic blood pressure. So there's fluid. So what we're going to do is try to remove the fluid. Pericardiocentesis is the treatment. Next slide. So cardiac dysrhythmias, normal sinus rhythm, regular sinus rhythm, you expect. Atrial and ventricular rhythms are regular. The heart rate is usually 60 to 100. So this is normal sinus rhythm, right? This is what you expect. You see a P wave that is followed by a QRS that is followed by a T wave. The PR interval is within the normal range. And if you look at the distance from each QRS, it's equal, right? The rate is between 60 to 100. So that's normal, right? Next slide. So normal tracing. So you're going to know it's normal because the P wave is there. The P wave configuration is constant. Each P wave is followed by QRS complex. Each complex are normal width. The interval between the QRS and the complexes are equal. The heart rate is between 60 and 100. So that's why it's called normal sinus. Next slide. Sinus bradycardia, right? It's originating from the sinus node, right? So the heart rate is slower, however, slower than the 60, right? Sinus tachycardia origination SA node is still the same, but the heart rate is faster than the normal, which is greater than 100, right? But one thing you need to understand is that sometimes, especially with athletes, the rate may be lower, or maybe they may be on drugs such as beta blockers. All right, next slide. So here's the sinus bradycardia. Again, atrial and ventricular rates below 60 beats per minute, right? Sinus brady is present if the heart rate is lower than 60. The P waves are there and it appears in regular rhythm, right? The treatment is, usually symptomatic. So if the person is not having any symptoms, you're not going to treat it. But look at it. See how the distance between the PRS and QRS, widens because it is, it's slower. It's slower, But if it's too low, you give a drug called atropine to bring up, right? Atropine. Next slide. Supraventricular tachycardia. You see the difference? You see the other rhythm that we just looked at. See how this looks different, right? So the rhythm originates from the SA node still. The atrial and ventricular rhythms are regular. The heart rate, however, look at it, it's above 100, right? But enough to cause symptoms, right? So the patient may have syncope, dizziness, hypotension. Valsalva maneuver to try to slower the rate. So bear down and cough and hold your breath. That can help lower the heart rate. Adenosine drug that is used, cardizem, can also do it. Massaging the sinus, carotid sinuses, all done by a doctor. And cardioversion if they're symptomatic. So really fast heart rate, right? So vageling down the Valsalva maneuver, telling the patient to bear down and cough, that can do it. So rather than waiting for the doctor to come, those are something that you could tell somebody to cough if you've seen the heart rate is really, really high like that. Next slide. Atrial fibrillation. See the difference here? So what you see is that if you look at the QRS complexes, see how they're not consistent, like the distance between one to the other. So there are no P waves. Instead of P waves, you see this fibrillatory F waves with the rate that is usually high, usually greater than 350 per minute. The interval between the QRS complexes variables, and there's no apparent rule in the rhythm of QRS complexes. So this is what we usually call regularly irregular rhythm, right? So cardioversion, Coumadin is used to prevent blood thrombi leading to stroke. So these guys are on thrombolytics, usually Coumadin. So you got to know the antidote for Coumadin when the patient is on it. Next slide. Ventricular tachycardia. See, look at the rhythms, look at the strip so you can see the differences in it, right? So the rhythm originates from the ventricle, right? No visual atrial rhythm. Ventricular rhythm is regular, abnormal, and it's usually wider than 0.12 seconds. The rate is above 100 and usually less than 200. So it can cause cardiac arrest if it's going so fast that the blood couldn't fill. The treatment, if the patient has a pulse, you treat them differently. If there is no pulse, then you do CPR. Okay? If there is a pulse, amiodarone or maybe cardioverter. Next slide. Ventricular fibrillation, very different. Fibrillation is, look at the rhythm again. The ventricle, the part that sends the blood out into the systemic circulation, is fibrillating. It's not like doing what it needs to do. So it's squivering, fibrillating, and the blood, there's no blood that is being ejected or even entering the atrium, which is not good. So cardiac arrest. So CPR, defib. So you want to defibrillate immediately up to 3 times. So 200, 300, and 600 joules are the new guidelines. All right? Next slide. So there's different types of defibrillation. There's automated external defibrillator pads. There's internal ones that the patient can have. So now you have pretty much, most facilities have, automated defibrillators that should be used. Because the older person has cardiac diseases, more chance that they have cardiac disease. When you're calling for help for CPR, that's one of the reasons why you call for help first, rather than for the pediatric patient, you start CPR and then you call for help, especially if you're there by yourself, right? But if more than one person is there, then as the other person is starting, somebody else could be calling for help, but generally will. If that means you by yourself, an adult, you will call for help, and then after you establish that the patient is not responsive, you will call for help and then start. In a child, you start and then call, right? Because the reason why a child may have cardiac arrest is not because of cardiac disease. The number one reason is because of foreign airway obstruction, right? Whereas the adults, the reason why is usually because of cardiac conditions. Next slide. Asystole, right? Flat, no electrical activity. Flat, no electrical activity, right? So many things can cause it. Okay, next slide. And then you have pacemaker that the patient may have. It could be temporary or permanent, that places the electrical stimulation and maintains the heart rate with the patient intrinsic pacemaker when that fails to provide a perfusion rhythm. So when you do the EKG, it looks different for these guys. It looks different. Next slide. So it's usually placed in the upper chest. And you should be able to feel it. Most people can feel it. Next slide. Here's the different types. So permanent, so the battery is under the skin. You have temporary, the battery is outside the skin. And then there's different types of pacemaker. Transvenous, epicardial, transcutaneous, which is usually done for emergency. When you put the pacemaker in, they have different modes. So asynchronous one, which one at present time without fail, and then synchronous or demand. When the heart rate goes below the set rate, then it kicks in. Next slide. And then there are different settings. Again, there is override pacing. So if the patient has a problem with tachyarrhythmia, the pacemaker can sense it, it speeds up and go fast, and then take over the rate. So it takes control of the heart rate and brings it back to normal. I think it's brilliant. All right. Next slide. So here you have, again, permanence in place. It says after it is placed, the patient needs to keep the left arm, in a sling, or at least close to the body for approximately 3 days, so that the wires that are inserted would have time to create a scar tissue and become more stable in the heart. if there's hiccups, recurrent hiccups after a pacer surgery, this is a sign that the electrodes may have displaced and the patient will have to go back to surgery to put them back into the correct area. So it's really, really important. Hiccups. Next slide. So program rate, so the client should know the rate that medically, by wearing a medical alert bracelet, signs of battery failure, and when to notify the physician. So examples such as dizziness, weakness, sudden weight gain, all of a sudden they're gaining weight, right? Persistent hiccups, right? Checking the pulse daily, maintaining dietary, and report sudden slowing or increasing of pulse. Next slide. Other things that we can educate the patient is the signs and symptoms to report. So if they have a fever, redness, swelling, drainage from the insertion site, dizziness, fatigue, shortness of breath, chest pain, swelling of the ankles, when pacemaker identification and med alert, and instruct the patient that if any unusual feelings occur when near any electrical device, to move 10 feet away and check the pulse. Next slide. Wear loose-fitting clothing, avoid any contact sports, inform all the people that take care of them about the fact that they have a pacemaker, because the most medical appliance can be used without any interference with the function of pacemaker, but it's important to be cautious about that. If any unusual feelings occur when near any electrical device, again, move away 5 feet away from and check the pulse. Next slide. All right, so now we are talking about congestive heart failure. Heart failure is inability of the heart to maintain adequate circulation to meet the metabolic needs of the body because of impaired pumping function. Okay, to sum it up, it's an inability of the heart to function as a pump. It could result from many different things, right? It could result from any condition that impairs the contraction of the heart, any condition that increases the workload of the heart. The leading cause, of course, will be hypertension and coronary artery disease with myocardial infarction and MI, with myocardial ischemia and MI. So what you see is that the cardiac output diminishes in the peripheral tissues that are not adequate, pathophysiological, not adequate to perfuse. So what you end up seeing is the heart tries to compensate by having the sympathetic nervous system stimulated, and the arteries and the veins, they try to constrict, and the venous return increases to the heart and increasing preload. And then you see the renin-angiotensin-aldosterone system activated, which tries to help the salt and water retain. And then the heart chambers dilate, which end up leading to ventricular hypertrophy. That leads to reduced cardiac reserve, and then leads to either the classification of right versus left side heart failure. All right, so there's a difference between the two. So left side heart failure is inability of the heart to pump, and specifically the left ventricle, right? So there are some manifestations that you will see to suggest left heart failure. So you see pulmonary congestion, because what's happening is when the heart fails, the left ventricle is inability for it to pump. And remember the way your blood flow, right? So from inferior superior vena cava into the right atrium, the tricuspid valves open, the blood goes into the left ventricle, right? And then pulmonic valve open up, the blood goes through the pulmonary artery to the lung, and then oxygenation takes place, and then comes back through the pulmonary vein into the left atrium, right? Mitral valve, and then from the left atrium it goes into the bicuspid valve, the mitral valve open up, it goes into the left ventricle. The left ventricle is bigger than the right because the left pumps into the systemic circulation. And the blood is ejected out into the systemic circulation. Now, when that left ventricle fails, because remember the blood is supposed to open, the valves are opening, and then the blood flows forward, right? But when the ventricle fails to pump, right? When that heart fails to pump, when that left side fails to pump, so which means that the blood that's supposed to go out is not going to go out, it's going to back up. Where it's going to back up? Well, it's going to back up where it came from, right? So the left side came from where? Came from the lung. So it's going to back up to the lung. So that's why you see signs and symptoms or manifestation that tells you that the lung is in trouble. So how do you know the lung is in trouble? So they usually have pulmonary congestion, right? Pulmonary congestion. So dyspnea on exertion, orthopnea, right? And then you see other signs, so such as reduced cardiac output, right? They're going to be tired and they're not going to be able to tolerate activity. They're not going to be able to tolerate activity, right? And they may go into acute pulmonary edema, right? So if it's a left side failure, it's different, right? Because the blood is coming from the left side, comes from the atrium into the right ventricle. So if that right ventricle is not pumping forward, the blood is going to back up, right? It's going to back up where? It's going to back up where it came from. So where does the blood from the right side comes from? From the areas such as inferior and superior vena cava, the sinuses, the liver. So you see signs and symptoms that point to where the blood came from. So they would have peripheral edema because the blood that comes from the lower extremities that's supposed to drain, now it's backing up, right? So you see abdominal distension, you will see jugular vein distension, you see fatigue and activity intolerance and abdominal distension, right? So what are some of the manifestation? Again, ascites, liver, spleen, enlargement, and tenderness, right? And usually a left side heart failure can cause a right heart failure. But you could see a right heart failure from people that have like respiratory condition, like your COPD or cystic fibrosis. Those kind of things can cause right heart failure. All right, so again, manifestation, and usually because of the forward effect, right? The forward effect. So activity intolerance, weakness, dizziness, syncope, right? Versus the backward effect, shortness of breath, dyspnea, orthopnea. This is for the left side. Cough, tachycardia, crackles in the lungs. The right side, you see the JVD, peripheral edema, anorexia, nausea, abdominal distension, liver, spleen enlargement. All right. And we talked about collaborated tests, so we can do cardiac, hormone levels such as the BNP, serum electrolytes. We can do chest X-ray. We can look at echocardiogram, EKG, ECG. We can also do hemodynamic monitoring, such as trying to see the cardiovascular function, put in a cath through the central vein, pulmonary artery used to measure the central venous pressure. That will be elevated in a heart failure. Let's see, what else here? So now, let's move on to next slide. All right, so now we're talking about the collaborative management again. So now we're going to use, medication here. So medications, there are many different types of medicine. There's ACE inhibitors. There are angiotensin II receptor blockers. There could be diuretics that are used, inotropic medication, vasodilation, bilateral meds. So the nitroglycerin can be used as a vasodilator, and the drugs to help increase Inotropic contractility, really big deal, or digoxin. So the job of a nurse is to monitor the dig level, make sure that it's less than the toxicity level less than 2, making sure that they have the antidote on site, digibine, making sure that you assess for signs and symptoms of toxicity such as nausea, visual disturbances, confusion in the geriatric client, beta blockers such as coregs, angiotensin converting enzymes, which would help to decrease the hypertension, the ACE inhibitors, the endopril. So you got to watch, that's PRIL. There's different time, vasotec, lisinopril. You watch for bronchospasm as an adverse effect. Morphine can be given to help with pulmonary treatment. So your job, please just make sure that you go and review all of the different drugs and see the adverse effect and how to monitor for your client that is taking these drugs. Next slide. Also, other things you can do is diet and activity is really important. So low sodium diet, bed rest during acute phases, activity to increase that gradually, oxygen, elevating up the head of bed so that they can help. Try to identify any precipitating factors that may exacerbate the condition. Daily weight, exercise again, but with activity. Avoid extremes in the weather when exercising. And sometimes they can also put some implantable devices to help, pacemaker or defibrillator, depending on what's happening with the client. They may do surgery, cardiac surgery, as a collaborative management. So it's important with transplant of heart to monitor for infection and rejection. That always become a concern, and so these guys are put on immunosuppressive drugs. So pretty much the priority is to prioritize the nursing care and focusing on oxygen demand and reducing the workload of the heart. Health promotion is also very important so that we teach our client measures to prevent cardiovascular diseases. Assessing frequent, and careful assessment, making sure that you can tell when something is wrong. And some of the subjective data that you should collect from these guys when it comes to assessment is, any complaint of shortness of breath. You want to find out about their level of activity, because you could tell if they cannot tolerate activity. The number of pillows that they use to sleep, because of apnea, people that have heart problems, they have to they pile the number of pillows. They can't sleep on one pillow or flat. Ask about any swelling of the legs and feet. Ask about any changes in their weight. Any their appetite, nausea, any abdominal discomfort. Ask about any history of MI or other health diseases that they may have, stressors that they may have, any respiratory infection, like I said, COPD or other condition, any risk factors that they may have that would put them at risk. So history of tobacco use, diabetes, high blood cholesterol levels, smoking, alcohol intake, assess the understanding of the disease and the treatment and compliance with the activity prescribed things for them, their diet and the use of salt. So that's subjective. And then of course you want to do your objective data, which means you got to look at your vital signs at rest and changes when there's activity. So if you're saying that a nursing diagnosis, they're not tolerating activity, is you want to look at the changes in the vital signs with activity to support your diagnosis. Cardiac rhythm and any cardiac dysrhythmia, Also look at dyspnea with any relationship with activity, right? So the oxygen saturation when they get up and walk, that would also tell you if they're tolerating the activity or not. Any changes in their skin, the temperature, the moisture, and the capillary refill. The veins, look at the veins, see if they're distended. The heart and lung sounds, we're going to listen. Usually there's a presence of S3 or S4 heart sounds. And when you auscultate, you may hear wheezing or crackles. Monitor the intake and output. These are objective stuff, things you can validate that are measurable. Also, take the daily weight. Assess their level of consciousness, any anxiety or fear. Look at the pulmonary artery, the cardiac output. Monitor the lab tests, so the BNP levels, the serum, the electrolyte levels, the digoxin levels, and any arterial blood gas levels that they may have. Identify any potential complication that may come from having heart failure. So acute pulmonary edema, any liver or kidney failure, any change in their mental status. Assess for any decrease in cardiac output. How do you know that the cardiac output is low? So the urinary output, the oxygen. Make sure that you are educating them about the meds. So take it to rest on a quiet location. Monitor, like the different nursing diagnoses that they may have. So decreased cardiac output is one. So what do you do for decreased cardiac output? Monitoring the urine output, monitoring the oxygen level, give the medication, rest and quiet. What about another nursing diagnosis? Fluid volume excess. So we're going to monitor the I's and O's, the daily weight, put them in Fowler's position, diuretics, fluid restriction, another nursing diagnosis is activity intolerance. So you're going to monitor your vital signs, give them rest periods, assist them with care, progressive activity plan, and small frequent meals. So also what we need to do as a nurse is to definitely do some documentation, right? Note any changes that you may have. The patient's response to any of the treatment should be documented, and referral, and so forth. Next slide. So now we're talking about the cardiac valve disorders. Next slide. All right, so as I talked about the valves between the different, the chambers, the valves between the atrium and the ventricle, are called the atrioventricular valves, and the ones, and that's the tricuspid and the mitral valve. You see still in this picture, and the ones between, adjacent to the right ventricle and the aorta. Those are called semilunar valve. Those are aortic valve and pulmonary valve. Next slide. All right, so you can have some problems with the valves. You could have them so that they are narrowed, or stenosis. They can regurgitate or prolapse. Next slide. All right, so let's talk a little bit about these valves. So the valves, you have mitral stenosis. So what you do see here with the mitral valve stenosis, you have the valves, the leaflet, they fuse, right? And so usually you can see, like, you can observe dyspnea on exertion, and palpable thrills. With the mitral regurgitations, the valves do not close, right? They do not close completely. And then you have mitral valve prolapse. Here generally we don't know unknown cause, but may relate to some type of inherited collagen defect, usually seen between young women aged 14 to 30. And then you have aortic stenosis. It's idiopathic, can be congenital, or it could be due to rheumatic heart disease. So what you see is that the left ventricle gets larger, hypertrophies. And these individuals are usually at risk for sudden cardiac death. This is why one of the reasons why we ask for ask the patient about like sudden death in the family. So as you're doing your history, because you want to figure out if somebody has something like this, especially for kids that are playing sports. The aortic regurgitation, the aortic valves fails to close completely, so it could be mild to moderate. So palpitation when lying flat is usually at the C, and they also have angina. All right, so pretty much usually the key is you just find out the manifestation. Usually hear murmurs, and then you see some the EKG will show some signs of hypertrophy. Murmurs are classified differently, so usually in mitral stenosis, the classification, usually the timing of the murmur is usually like diastole, and it's usually located like in the apex, fifth intercostal space, right? And then you have the mitral regurgitation. The timing of the murmur is usually systole, and it's usually identifying the apex, right? And aortic stenosis, timing again is systole, and usually it's located in the right sternal border. And then aortic regurgitation is usually early diastole, and it's usually seen in the left sternal border. So it's important to kind of have an idea that a murmur may tell you that one of these issues are taking place. And what you see is collaborated management. We're going to do echocardiogram. You could do cardiac cath, and usually these guys are put on prophylactic antibiotic, to avoid more complication to the heart. They may have percutaneous balloon valvuloplasty, and usually treatment is very similar to any type of coronary revascularization. Or we can try to resect or replace the valve, right? And so when they do a balloon valvuloplasty, so what happens is that the balloon catheter is positioned across the stenosed valve, and then the balloon is then inflated to increase the size of the valve opening, right? So our priority in nursing care is to focus on decreased cardiac output. So we want to monitor the vital signs, hemodynamic measures, cardiac output, measure that every 8 hours, monitor the intake and output. We're going to weight the patient daily. We're going to restrict the fluid intake. We can elevate the head of the bed, oxygen and medication. For activity intolerance, monitor the vital sign, gradually try to increase the activity and assist as needed. And continuum of care, so we want to prevent any rheumatic fever, explain all the tests and procedures, the medication, teach them on how to rest and evaluate for edema. Next slide. We talked about, the heart failure already. Next slide. This is also continuation of heart failure. Next slide. Continuation of heart failure. Next slide. Prophylaxis for dental work, and again, it's really important for any valve replacement. So this is the other two slides were out of place. So again, teach them about prophylaxis for dental work, colonoscopy, etc. Teach them to weigh every day and report any increase in weight overnight or 5 pounds in a week. Next slide. Pericarditis is an inflammation of the pericardial sac. It can be caused by many things, but specifically viral infection, complication after surgery, cardiac surgery 10 days to 2 months, or after an MI. Other idiopathic cause can be connective tissue diseases such as lupus, cancer, radiation therapy. Next slide. So the manifestation that you see for pericarditis are chest pain on inspiration, which works when the patient leans forward, lying down, or turning. You may hear pericardial fiction rub, and you may see symptoms of right side heart failure. Fever, elevated WBC, the SED rate is elevated, and atrial fibrillation is not uncommon. A 12-lead EKG may have elevation in all the leads and can worsen to cardiac tamponade. Next slide. So what are some of the collaborated management? Anti-inflammatory drugs, NSAIDs and steroids, of course, to decrease inflammation and to treat the pain. One thing about the steroids, you got to make sure that you monitor because it can cause immunosuppression, increase in blood sugar, bone density decrease, slow down the growth of a child, cause Cushing syndrome, adrenal insufficiency. So it's really important to monitor the drug and teach the patient not to stop the drug abruptly. We're going to monitor for cardiac tympany, so you're going to hear the distant heart sounds like we talked about. There's jugular distension, and again, the treatment for cardiac tympany, as discussed previously with the complication, is pericardiocentesis, so aspiration of the fluid. Next slide. So position the client upright and leaning forward, monitoring for the signs of cardiac tympany again, and then gradual increase in the activity, and teach them to avoid aspirin or other type of anticoagulant because it may increase the risk for cardiac tympany. Next slide. Ineffective endocarditis, again, the valve and the endothelium surface of the heart become infected. The most common in elderly clients, possibly due to the loss of their immune system, or those that have any prostatic heart valves. And also IV drug users, cardiac valve disorders, also predispose the client. Next slide. So what are the clinical manifestations? They're usually slow in onset, but you'll see, flu-like symptoms, anorexia, weight loss, joint and back pain are common, and fever may be absent or intermittent. And you may see like splinter, hemorrhage, petechiae, under the nails, petechiae in the mucous membrane or conjunctiva, murmur, may also be heard, and the patient may have a headache. Next slide. What are some of the complications? There may be arterial embolus caused by fragments that is breaking loose and travel to the distant organ. Positive blood culture, echocardiogram, using the TEE can definitely help diagnose. Next slide. Collaborated management is intravenous antibiotic, based on the culture and sensitivity. Anticoagulants may not benefit. Prevention is better than cure, so prophylactic antibiotics prior to dental work, surgery, any type of other ways to have a stream of infection. Next slide. Hypertension. Hypertension is 90 to 95% of the cases are unknown. 5 to 10% are due to secondary causes. There are some genetic tendency, obesity, stress, and extreme excess sodium intake. Prolonged hypertension eventually leads to many problems, such as, making the heart large, kidney failure, eye, and stroke. The higher the blood pressure, increase in the coronary, the more problems you have with the brain, the peripheral vascular system as well. Next slide. So what is hypertension? So now they're saying pre-hypertension is blood pressure less than 120/80. So normal has to be less than that. 120/139 and 80/89. Stage 1 is 140 over 159 and 90/99 systolic, and then stage 2. And usually blood pressure has to be assessed more than once before you can say someone is hypertensive. Next slide. So what are the clinical manifestations? Hypertension is known as the silent killer because most people don't show signs and symptoms. But some will report headache, especially early in the morning, occipital headache, And in order for us to diagnose it, we have to take in the blood pressure, both arms after sitting and at least 30 minutes apart after smoking and drinking caffeine to get the most accurate reading. Want to make sure that we have the right cuff. There are some risk factors: family history, age, diabetes, obesity, heavy alcohol, high sodium intake, and low dietary intake of potassium. Because remember the sodium potassium pump, so they help balances out. But if you're only taking one of it, not the other, then you have more excess of one. All right? Calcium and magnesium. Next slide. So what are some of the collaborated management? Well, high blood pressure, we want to lower the blood pressure. There's many different drugs to do so. There are diuretics, there are beta blocker, there are ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, alpha blockers. What I expect of each student is to go in and look at each of those classifications, right, the similarities and the adverse effect that you want to pay attention to, and the contraindication for each of these drugs. So the trend is to combine some of the drugs, but you always want to start off with lifestyle modification first. Secondary hypertension, something else is causing the hypertension. So in those cases, we want to treat the cause. Is it because someone has kidney failure? If it is, then that situation is going to be handled with probably hemodialysis or so forth. Is it a tumor that is secreting a lot of catecholamines that is causing the hypertension? So we can fix that. So secondary hypertension, we know what's causing it, and if you treat the condition, it goes away. Primary is unknown, and that's the major type of hypertension, and that's what we usually treat. Next slide. So here are some of the different types. So to help you remember, the ACE inhibitors, they end in pril, right? And these are the different types. The beta blockers end in LOL. The calcium blockers, the mills, the pins, right? Next slide. This is another slide to show you and just to help you. So it tells you about the different types, the classification of each drugs again, like calcium channel blockers, where they are. So you're trying to learn this different one. The diuretics. So you have the thiazide diuretics. You have the potassium sparing diuretics, right? Spironolactone. All right, the vasodilators. You have the central sympathetic drugs. So you've got to learn all these different drugs. Next slide. Another great slide. All right, so the guidelines for selecting the most appropriate first-line antihypertensive drug. Usually after lifestyle modification, the next one they usually use are diuretics. The second column is telling you about the indication of it, right? Heart failure, elderly clients, and those that have systolic hypertension, and possible indication, diabetics. Contraindication, you don't want to give the thiazide diuretics to someone who has gout, right? Because of the uric acid, right? So I do want you to review this and make sure you understand each one of those. Next slide. So nutrition management for hypertension, again, it's a lot of teaching, the DASH diet. So you're going to teach them about lifestyle modification, diet, exercise, management, making sure they follow up with their physician, making sure they take their blood pressure at home to ensure that, it's not elevated, making sure they take their drug on time and regular, not miss the prescription. Make sure they follow up with their providers at least annually, if not every 6 months. All right, and eating diets that help reduce, canned food. Canned food has a lot of sodium and so forth. All right, next slide. All right, so peripheral vascular disease. Peripheral vascular disease is our next content, and the pathophysiology. What happens here is you see generalized atherosclerosis, which is the plaque developed and hardens, right? And when that happens, the lumen gets narrowed, and then there is thrombus that is formed, right? And if the patient have peripheral vascular disease, they're at risk for having CAD as well. Next slide. So peripheral arterial disease is a chronic deprivation of oxygen and nutrients to the lower extremities, right? Usually caused by atherosclerosis, sometimes called the lower extremity arterial disease, right? Manifestation are in different stages. Stage number 1, usually the patient is asymptomatic. However, if you listen, auscultate, you would hear bruit or aneurysm may be present. If you palpate the pedal pulses, there will be decrease or absence. Next slide. So that's stage 1. Next slide. Stage 2 is claudication. Here you have pain and burning in the calf when the patient walks. But as soon as they sit, the pain goes away, right? And stage 3, which means it's getting worse, so the pain is even at rest. So the leg pain while resting awakens the patient at night. All right, so they also have numbness, burning in the distal extremities, the toes, the achy heel. The pain is relieved by lowering the extremities to the dependent position. Next slide. Next slide is stage 4, and with stage 4 there's necrosis. Necrosis, there's no artery supplies the blood, right? So when you don't have any supply, you're going to see signs that says perfusion is not good. So ulcer, blackened tissue on toes, plantar area and heel, and gangrene order may be present. All right, next slide. So what are some of the collaborative management? Well, Trendil is a drug that is used to help increase the blood cell flexibility. Aspirin and Plavix to prevent any platelet clumping. We need to control the blood pressure to maintain perfusion without any vasoconstriction. We may do angioplasty to help dilate the artery with a balloon catheter and stent that is placed to keep it open. Nursing recovery is usually similar to that of PTC as discussed previously. Next slide. So arterial revascularization, again, to try to bypass to improve the arterial blood flow. Nursing management, you're going to teach them exercise to build the collateral circulation. You're going to keep them, position them to avoid crossing or raising the legs above the heart. Try to promote vasodilation, so warm environment, socks, install shoes, and never apply direct heat to a sensitive because their sensitivity is less, and drink, encouraging the patient to drink plenty of fluids to help maintain the blood flow. Next slide. Promote vasodilation. I think this is a repeat. Next slide. And of course, avoid cold, extreme, emotional stress, caffeine, nicotine, crossing the legs, and teach to observe the skin of the lower extremity to identify problems early. Next slide. So we may do an arterial bypass, and so when you do the bypass, we're going to monitor for graft occlusion, so color, the sensation, warm, check in every 15 minutes at first, and then using Doppler to assess the pulses, and marked in surgery, assess for pain. Pain after surgery may indicate any immediate occlusion, and promotes the patency of the graft by keeping it normal, tensive, so keep the blood pressure normal, limit the range of motion of the affected limb, avoid bending hip and knee so that the blood can flow better. Next slide. Monitor for compartment syndrome, so here you see insufficient blood flow. So that there's insufficient blood flow because there's increase in pain, so that's one P. Sense of fullness, paresthesia, that's another P. No pulse, that's another P. And paralysis. So these are things that the patient needs to report to us immediately, or if you assess it and you assess this information, you report immediately. Next slide. Venous insufficiency is another condition here. So venous insufficiency is usually seen with prolonged venous hypertensive stretches the veins and damage the valves. So the blood backs up, creating edema, and stasis results, leading to stasis, ulcer, swelling, and cellulitis. All right, next slide. So there is a difference between the two, arterial insufficiency versus venous insufficiency. So arterial, there's narrowing of the arteries, commonly in the pelvic and legs. Venous, inadequate return of blood flow, right? So the blood from the legs to the heart, inadequate. So look at the symptoms, a little different, right? So you have cramping, pain, tired legs, or hip muscle that worsens during walking activity and subsides with rest. That is arterial. Versus venous symptoms. So here they are tired, heavy, achy. The pain is worse with standing and improves with leg elevated and activity. So the other one, rest makes it better. This one, activity makes it better. So those are distinctive difference. They look different too. One is artery, one is vein. All right, next slide. So here's another really good slide to show you the differences again. So we're going to show you different slides until you get it so you can understand the differences. Arterial manifestation. Here you see diminished or absent pulse, because remember the artery, when you feel the pulses, that's the artery, right? The vein, we're not checking the pulse, right? So the pulse will be normal, right? Artery, if you look at the skin, will be smooth, shining, and dry, no hair. Whereas with the vein, brown patches, discoloration of the lower legs. There's no edema for artery, but it's dependent edema for vein, right? Because remember, the vein is supposed to take the fluid back to the heart. So it's dependent, it's efficient, right? Round, regular shape, painful ulcers on distal foot, toes, webs of the toes. That's artery. So do they have problems? They have irregularly shaped, and it's painless ulcers on the lower extremities. Dependent rubra, dependent cyanosis and pain, right? Pain, pallor and pain when legs are elevated. Pain relief when legs are elevated. Intermittent classification, right? No intermittent classification. Brittle, thick nails, normal nails. All right, next slide. All right, so this is also showing you the manifestation of insufficient vein. So you have, see the difference? Look at that also. Superficial venous reflux is progressive, and if left untreated, may worsen over time. All right, next slide. These are the risk factor of venous insufficiency: gender, age, pregnancy, heredity, standing occupation, obesity, prior injuries, sedentary lifestyle, right? So that's the risk factor. What are the symptoms? We talked about them early: leg pain, aching, but activity helps it. Ankle swelling, feeling heavy, discoloration, open wounds and sore, restless legs, venous varicose vein. All right, that ends this lecture. Thank you very much for listening.